As Morning Live focuses on newly appointed ministers this week, today we speak to the Minister of Health, Dr. Motsoaledi. Now, Dr. Motsoaledi is not new to this position following his previous 2 terms as Minister of Health. Minister Motsoaledi joins us virtually to reflect on the Department of Health in South Africa, its challenges, his hindsight perspective, and of course, his vision as he comes back into this ministry. Dr. Motsoaledi, thanks so much for your time. Welcome to Morning Live.
Good morning, Sakina. Good morning to the viewers and listeners. And thank you very much for having me.
Absolute pleasure. Now, Minister, you recently said you were stunned when you were brought back to this position. And I couldn't understand that because when the President signed the NHI bill, one of the first things I thought was that he would probably bring you back to this portfolio, given your previous tenure. So you didn't anticipate coming back? Why not?
Not at all, Sakina. I'm surprised. What made you think like that? How could you be so predictive? I mean, what was telling you to predict something like that and it actually happened? I never ever thought about it, I must confess.
It's the work you did in that particular department and in NHI in the initial stages, because I remember you calling us to orientate us, to tell us about NHI, how it's going to work, how the funding model is going to work and all of those things. So in my mind, it made perfect sense. But here you are, Minister. So as you look at this ministry, first port of business, what are your thoughts in terms of what you'll have to do?
It's a lot of work, Sakina, a lot of work. Because remember, when we bring in NHI, we are bringing a transition, a very, very big transition in the country. And if I may quote the Lancet, I'm sure you are aware, one of the 4 well-known medical journals is the Lancet, which is a British medical journal. In September 2013, in its editorial, it says since human beings started populating this planet, there's only been 2 transitions in healthcare, and the 3rd one is about to happen. And it names the first transition as the time when the world brought in clean running water and sewerage, and they call that a demographic transition in the world. Because small as it might look, it changed populations around the world, it increased life expectancy. People who used to die very young because of infections started living longer, and that's how life expectancy changed around the world. The second transition, it calls demographic, it's about immunization. To say the second transition is about immunization. It's called epidemiological transition. When vaccinations was brought in the world, you may remember, Sakina, there was a disease called smallpox that annihilated millions of people together with other infections. But after Edward Jenner brought in immunization for smallpox, other diseases were immunized for. And the world underwent this epidemiological transition. Now they are saying the 3rd transition is true. It is how healthcare is financed by countries around the world. And that financing of healthcare in South Africa, we call it NHI. So it's a huge transition, which is recognized the best in the world.
So, Minister, with all of that, we came from that COVID-19 pandemic, and as you say, there's so much going on. We now have mpox that we are dealing with, and I saw yesterday a report, successfully so. But there is a lot going on, and there's also so much contestation that came with the passing of the NHI legislation. And I think for a lot of South Africans, this is a big one. How do you foresee cooperating with colleagues in the executive, given that some political parties are opposed to the NHI and they are now part of this government of national unity? Some have even threatened to bring legal action against government if they continue to implement NHI.
Well, Sakina, there are already 2 legal actions, by the way. So on my first day in the department, I spent 3 hours with 3 senior counsels listening to this issue, because there are already challenges. By the way, the first challenge has been won by government. I'm sure you are aware that there's been a challenge by Solidarity when the department started setting up structures and appointing people to take the issue of NHI forward, because it was not there before. There was no DDG or Deputy Director General in charge of NHI before. When he was put in and his staff came to the board, Solidarity rushed to court, but they lost that one. So the first round has already been to government. Now we are going to go for second round, and there will be many more. We are expecting more from the way they've told me. But we'll sit down and defend it, because, Sakina, let me say, from where I'm sitting, I think many people oppose NHI without knowing what it is. I thought us as the state perhaps did not sit down and explain very, very well. And part of my work is to go and explain to people exactly what NHI is, because I have heard some of the criticism that this is not the NHI that we are introducing in the country. This person is talking about something else. You know, for instance, many call it universal health care, whereas the World Organization has already named it long ago as universal health coverage, because the central issue here, Sakina, in NHI, is not a healthcare system as people believe. That no, it's an expensive healthcare system. We need to prepare. We need to have infrastructure and technology and human beings first. So they believe it's some sophisticated type of healthcare. It is actually healthcare financing, meaning it deals with one of the 6 pillars of a healthcare system as pronounced by the World Health Organization. And what are the pillars? The World Health Organization clearly defined that for any country to run their healthcare system very well, it needs to have 6 pillars. And the first pillar is leadership and governance. What is the leadership of that healthcare system and how is it governed? The second one is essential medicines and other commodities that are needed in healthcare. The third one, and I'm not really naming them in any order of importance, I'm just naming them as they come to my head. The third one is human resources for health. It's called the health workforce. What does the workforce consist of, and what does it do, and where do you place this health workforce, like you place an army during a war? The fourth one is healthcare financing. How is the healthcare of that country financed? How do people get cured when they are sick without them having to suffer what is called a financial catastrophe? The fifth one is health information system, IT systems, so that when a patient moves from one area to the other, doctors or health workers know what the patient is all about. Because presently, without an interlinked system, a person can go to 10 different doctors in both public and private, and they'll always start from the beginning, and that's not good for health. The last one, the 10th one, is health service delivery systems. What are the packages of healthcare that population know that they are due to them? For instance, when a woman is pregnant, whether she's rich or poor, what can she expect? How is the country to take care of her about the pregnancy until she delivers? And when she delivers, what are the packages due to the new arrival, to that baby? That is healthcare delivery system. So there are 10. As you can see, one of them is healthcare financing. Now, that to me is the center of all the pillars of healthcare, because without financing, there is not much you can do. That is why all over the world, Sakina, ministers of finance are regarded as perhaps the second in charge to the president or the head of state in that country, because without them, everything goes flat. Now, can I explain this healthcare finance in South Africa? Why it needs to change? Why it has to be called a transition? At the moment, Sagina, this is how healthcare is financed in South Africa. According to the World Health Organization, again, a country ought to spend 5% of its GDP, gross domestic product, on health, then the health of the population will be better if you do that. And now you must listen to me carefully. It doesn't say the budget. It doesn't say the state must increase the budget of health or so. It says the GDP, the total wealth of the country, 5% of it must be used to the health of the population. Now, in South Africa, we are already at 8.5% of the GDP on health. We have far exceeded the recommendation of the World Organization. Generally, countries in Europe are at 9%, we are at 8.5%. What it means is that we and countries in Europe are in the same WhatsApp group when it comes to the amount of money or wealth poured into health. Now the question is, where lies the problem? Because our healthcare systems are like chalk and cheese. You know, where is the problem? Yes, and here is the problem, Sakina. In South Africa, which doesn't happen in any other country, in South Africa, that issue of gross inequality comes in. You are aware that we are regarded as the most unequal country in the world. If you want to see what inequality means, come to the healthcare system. There's no other aspect of life that reflects this gross inequality between the rich and the poor than in the healthcare system. It's no longer about color as it was in apartheid. It's about the depth of your pocket. Now, in South Africa, this 8.5% of the GDP, which is huge, is divided as follows. 51% of that goes to only 14% of the population, and 49% goes to a whooping 86% of the population. But in this 86% of the population, lots and lots of responsibilities are put on the shoulders of that system. And in this 14%, it's light work. They are doing very light work. And if you want me, I can even quote figures for you if you so desire, if you have got time.
Yes, I want those figures, because this is one of the biggest issues raised around the issue of financing the fund. So let's talk about it, yes, Minister. Let's break it down and let's try to understand what goes where.
Yeah. Sakina, I've already said we are spending 8.5% of the GDP on health, which amounts to R500 billion. About 580 billion is spent on healthcare in South Africa. But 51% of it goes to only 14% of the population, and the remaining 49% goes to 86% of the population. Now, here is the burden, which I said I'll explain, and thank you for giving me time about figures. Let's start with birth, the beginning of a human being. Every year, 1.2 million women fall pregnant in South Africa, which means 1.2 new arrivals every year in South Africa in terms of birth. But this 1.2 million people, the private sector, that is carrying this 14%, because it's in the private sector, let me say, which is carrying this 14% of the population and carrying 51% of the GDP of the country. It takes only 140,000 pregnant women per annum. It takes care of only 140,000 babies per annum. It brings 140,000 babies on earth. This meager public sector, which is carrying 86% of the population, but spending only 49% of the GDP, is bringing in 1,060,000 babies into this world, is taking care of 1,060,000 pregnant women in the world. That's number one. Then we go to HIV/AIDS, which you know is the biggest killer. Was actually annihilating people. It is still the biggest killer, even though we've tamed it. If you remember, we have to put up the biggest antiretroviral program in the whole world. Now, there are about 5 million people, 5.7 million actually, people who are on ARVs. We still needing to move to somewhere around 7 million if we are to achieve the 95 defined by the international aid conferences. Now, these 5.7 million people who are being treated for HIV is the biggest killer in the country. only 350,000 are being treated in the private sector. The rest are treated in the public sector with this meager amount of money. Now we go to TB. People who are on HIV/AIDS, 80% of them are killed by TB. So it also goes into the bracket of the biggest killer. I don't know of any private hospital that is prepared to treat TB. All of the people who are suffering TB are treated by the public sector because it is not profitable to treat a disease like TB. Yet it affects human beings, and it's not profitable to the economy not to treat it. But it's not treated there. It is treated only by the private sector. By the public sector, because the drugs there are extremely, extremely expensive. Now, during Ebola, Sakina, if you remember, there was Ebola in Sierra Leone, in Libya, and Guinea. Something extraordinary happened, which you, members of the public, don't know about. There are many mine owners of South Africa in those countries. There are many people who are running mines, their own mines in those countries. Whenever they got a fever, they will immediately get a chartered flight because they've got their own flights, they've got their own planes. They immediately join into a chartered flight and rush to South Africa. Obviously, because healthcare systems in those countries are sort of at a very low level, I must say, and they get scared that they're going to die. They come to South Africa because they are millionaires or billionaires. They obviously rush to the private sector where they believe everything is kosher, everything is good. And how do I know about that? Because they started appearing in large numbers in public hospitals. We started seeing millionaires and well-to-do people there. And we got shocked, and we were curious to ask why. And they said, whenever you run a fever and you say, I'm from West Africa, they say, no, please, not through the gate of this hospital. Go elsewhere. Go into the public. Because why? They don't want to take a risk. And why? I'm not hating private health care, but I'm just stating facts. Because most of them are on the Johannesburg Stock Exchange. And a stock exchange is not a place to run health for the poor or for everybody else, Sakina, for me and you. It's a place where you deal with huge amounts of money, where you want lots of profits and you don't want any chances, you don't want any risks. And if poor people or sick people bring risk, you cannot take care of them. And now we cannot go on with that type of a healthcare system.
So for many people, Minister, the worry is, especially those who have medical aids, the fear for them is that they will now lose the ability to receive the health services that they pay for through these private funds that are the medical aids. That is a big fear for a lot of people. So can you put that into perspective? What will this mean for medical aids and those people who have it?
Let's start here, Sakina. How private are medical aids? Because when you say, I've heard this many times, by the way, that this is private money, why the state is meddling with private money. Let's start with exactly how private it is. Sakina, the public service consists of 1.3 million people. All 1.3 million people are subsidized heavily by the state for this medical aid you are talking about. They are getting a subsidy. If a person was to join a medical aid without a subsidy, they will not just afford. Only millionaires will afford. Ordinary people, no matter how much they earn in the state, they won't afford. They are very, very heavily subsidized by the state, including members of parliament, including judges, all of them. Some members of political parties who are criticizing this NHI are carrying heavy medical aids, heavily subsidized by government. By how much do they subsidize them? The 1.3 million public servants, that includes members of parliament and judges. I keep on quoting them, Sakina, and quoting myself because I'm a member of parliament, because we belong to the most expensive medical scheme in the country called PAMED. People believe Discovery is the most expensive. No. PAMED, covering members of parliament and judges, is the most expensive of them all and is heavily subsidized by the state. Now, the state subsidized this 1.3 million public servants to the tune of 71 billion rand per annum. That is a subsidy from the state. On top of that, everybody who is on a medical aid, regardless of who is working for, get what they call tax rebates from SARS. That is money from the fiscus. And those tax rebates are more than 30 billion rand. So out of this 580 billion that is spent in healthcare, already 107 billion or so comes from the state into subsidies of people who are on medical aid, which subsidies are not received by ordinary people, by ordinary men and women who don't fall within that bracket of earning. And that in itself brings a lot of inequality. So people who are complaining, they are complaining because they have to share with somebody who is poor. And I think the country is based on equality. It is no different, Sakina, from those who own land and who don't want to share with the landless. It's no different. It's exactly the same thing. And we need to tackle some of these inequalities in the country. Now, those people who say they are worried that they'll part with their medical aid, after being subsidized in the manner in which I've mentioned, most of their benefits come to an end around about September. There was a year in which my own benefit ended in September. I think it's 3 years back, 3 or 2 years back. They ended in September, despite of the massive amount of money I'm paying, which the state is also subsidizing me for. But it still came to an end. And when it comes to an end, where do they go for their health care? Some are on chronic medication. They come to the public health care system, where they are expected not to be charged anything untoward. And the public health care system takes care of them. So you have got 14% of the population which are double dipping, using both public and private sector. And you have got 86% of the population that consists of poor people who only use the public sector, which has got meager resources because all the resources are in the private sector. Now, it can't go on like that. We want everybody, rich or poor, to be able to use both systems if it becomes necessary, because some of the things exist in one system than the other. But rich people or well-to-do people, and here when I'm saying rich people, I'm counting all the public servants, teachers, nurses, the army, police, clerks, everybody who's working for the public service. And I'm also mentioning those people who work for the private sector but are on medical aid. They can use both systems, but other human beings within the same country can use the same systems. That's why in 2014, the Director General of the World Organization, when he was giving his speech opening the World Health Assembly in Geneva, said we cannot, as a world, keep healthcare systems that are a punishment to the poor, where there is gross inequality between the poor and the rich nation, but between poor people and rich people within the borders of the same country. She said we can no longer go on with that healthcare system. We need universal health coverage, which in South Africa we call NHI.
Well, Dr. Motsoaledi, I think very important that we do speak to exactly what's to be expected. I think speaking to the funding, very important for us to understand as a nation. But I do implore that we speak a lot more about some of the challenges that we do see. And we will make time for that, because I think the challenges that people point out are valid. The other day I was looking at a story in the Eastern Cape, I think a few months back at the beginning of the new financial year. They were already deep in debt in terms of the debt that they had to service even before the new financial year started. And this is not unique to the Eastern Cape. Those are some of the issues that we need to talk about. We need to talk about staffing issues and a lot of things that are not going correct in the healthcare system. But that's a story for another day. We thank you in terms of just touching base with the new ministers and their new portfolios. Dr. Motsoaledi, newly appointed Minister of Health, speaking to us there about coming back for another term, and also speaking to us about NHI, explaining to us some of the funding mechanisms and how this model actually is going to work.